Welcome to our session on research in European healthcare chaplaincy with projects and perspectives and different approaches. And we have a very strict regime of time. And we'll start with Niels Tentoom, who will give a presentation on unfolding the professional intuition, how doing research affects chaplains' professionalism. Niels Tentoom is a PhD student in the case studies project on chaplaincy healthcare in the Protestant Theological University of Groningen and the Tilburg School of Theology with Tilburg University. He has working this experience in different working fields of chaplaincy care. He worked, did some research in prison chaplaincy, university chaplaincy, and chaplaincy in healthcare. And since 2018, he has been an editor of theory and research of the Dutch Journal of Chaplaincy Care, Tijdschrift Geestelijke Verzorging. Wrong pronunciation, but please forgive my not existing Dutch. So I'll give over to Niels, and I'm looking forward to your presentation.
Right, thank you for this wonderful introduction, and also for at least seeing each other. And I share my screen in the meanwhile.
Perfect.
For seeing each other here and to present something of our research. I'm really looking forward to it. And today I will present some of my preliminary findings of my PhD study. Well, let's start. Research on chaplaincy is growing, and it is actually becoming part of the profession itself, and is also becoming part of the profession of the individual professionals. And the question is how to understand the role of research in their profession. And there are, for example, there's the term of research literacy. You see it on the slide, which is mostly distinguished between basic, intermediate, and advanced, and which is about the ability to understand published research and to apply it, or even the capacity to contribute to a research project that is carried out by other disciplines, or even to the capacity to be a lead investigator. And one can notice that all levels focus primarily on the contribution of chaplains on the development of knowledge by being involved in research. But it remains the question, what knowledge chaplains take back to their field? And that's where my interest is. The double role of the practitioner researcher seems to be a fruitful combination for both practice and theory. And there are indeed indications that cross-pollination occurs in the fields of chaplaincy. However, it's unclear how and what. And for that reason, I'm doing a PhD study focusing on this very knowledge gap. And the aim of my study is to understand the contribution of participation in research on the chaplain's professionalism. And today, as I said before, I want to show you my preliminary findings very briefly. First, I will say something about the project in case you don't know anything about it. Then I will say something about my methods, and then I will move quickly to my results and interpretations. Well, the Dutch Case Studies Project is a 4-year project in which 55 chaplains participate for 4 years in so-called research communities led by a lead investigator. They are analyzing, writing, and evaluating their case studies. These are all case studies of what they consider to be a good practice of chaplaincy. Both the case studies and the analysis are conducting following a detailed format in order to make all studies comparable. So this is not just general research they participate in, but a specific kind of research, which is collaborative participatory research. You can see in the left column that I'm conducting a mixed methods study. So first I have the qualitative part with interviews and participant observation, focus groups. Then a quantitative part, a survey among all chaplains that are participating, and then again some focus groups. For today's presentation, I have conducted 12 interviews with 6 participants. All interviews took about 90 minutes and had an interval of about 1 year between both interviews. And I analyzed them using Atlas TI And after the analysis, I went back to the chaplains for a member check. And during the analysis of my interviews, I found that one word in all its variations occurred relatively often. And this was the word awareness. It was used about 331 times, and that's quite often for 12 interviews. And that made me focus for today's presentation on the different meanings and processes that are referred to when chaplains speak of an increased awareness. Roughly 4 ways of becoming aware can be distinguished in the data. Becoming aware of one's knowledge, being aware in the moment, acting consciously, and becoming conscious of who you are. In Dutch, the word bewust zijn, bewust worden, is used in all these occurrences. And I elaborate on them subsequently. First, knowledge. In the format of the project, which I mentioned earlier, some questions are included regarding the role of theory in accompanying clients. Chaplains report that the question on theory at the beginning evokes uneasy feelings. As Simone says, we started actually in the beginning of the research community, and I formulated quite denigratory now, giggling about it. Theories, well, I just do it. But gradually we found out that altogether we share a fair amount of theory. They were apparently not used to speaking about their work in terms of theories, which correspond with other findings that chaplains in the Netherlands speak of their profession primarily in terms of attitudes and not of knowledge or aims or goals. And for some, there was even an initial resistance against theories. Ivan says, for example, in his first interview, that maybe someone made a kind of model on it in which he simplifies reality. Well, yeah, that's fine, but that's a matter of indifference to me. End of quote. While in his second interview, he says, yes, I am reading more consciously now. Because in the case study, the question from which theory is this derived is put very often. And I never know. Now, I do not only read it for myself, what I used to do before, but I can now also offer something that is not for myself. Now I can bring in a philosopher of a theory or a theory. Their knowledge, which is mostly learned during their initial education, has become implicit, interwoven with experience. And by means of their participation, they explicate what has become their professional intuition so that they know what they are doing and are able to use it more explicitly in accompanying their clients. Second way of speaking about awareness is about reflectivity. In the chaplaincy project, case studies project, the chaplains do not only learn about chaplaincy and knowledge about chaplaincy, but they learn to think and reflect as well. One of the participants notices that she is more aware of what comes into her mind in a situation, which gives her a sense of freedom. And Simone reports that the most important thing is in fact the deeper flow, that sometimes in the moment of the interventions or just afterwards when I leave the room, that I'm more reflexive, looking more to what has happened here. Not so much with regard to myself, but just as sheer, what has happened here? End of quote. This is precisely what Donald Schoen long ago has formulated as reflection in action, which is characteristic for the reflective practitioner. Reflectivity helps to mediate between general theories and the unique circumstances of practice. This aids professionals to come to good decisions in complex and relatively unknown situations that are typical for professions. Then, efficacy. Knowing what one is doing and being reflective helps one to act consciously. Making one's knowledge explicit provides an opportunity to balance possible actions and to make a considered choice. Quentin remarks that he moved from acting intuitively, which can be very wise and an art and very good, towards more thoughtful and conscious acting, whereupon various choices arise and various possibilities, resulting in acting more consciously, more professionally. The freedom that exists in the choice is necessary for discretion, which is considered crucial in professionalism. This helps chaplains to make thoughtful decisions for the sake of their clients. Acting for the sake of the client presumes acting purposefully and thus implies some sense of efficacy. Thus, the combination of explicit knowledge and reflectivity can lead to more freedom and thus helps chaplain to make discretionary judgment and act expediently. Then the fourth way is professional identity. A fourth way of becoming aware is becoming conscious of oneself by listening to their audio recordings of their conversations and by describing and discussing their practice. The chaplains become conscious of their way of working. Even more, they become conscious of what type of chaplain they are. They discover their professional signature. Like Simone says, what I'm doing, what I'm actually doing, what do I stand for, what is my identity as a chaplain? I reflect on that, yes. The clarification of their professional identity is not only connected to processes of awareness, but can be found across the data. Professionalism and professional identity, however, are complex concepts that are often used without being clearly described. The first, professionalism, constitutes of, I use a model by Rancic et al., which she distinguished between a collective frame and the individual side of professionalism. And the collective frame can be distinguished between an institutional frame, which is, for example, the frame of the hospital, and the professional frame on the collective part, which is, for example, a professional standard. At the individual level, one can distinguish between the professional self, so how they do consider themselves as a good professional, and their individual selves, their personal selves, just where they are also outside their profession. The clarification of the chaplain's professional identity in the case studies project affects multiple levels of professional identity. Some chaplains say that they acquire words to express what they are doing, and doing this collectively reinforces the collective professional frame of the chaplains. In the case studies, we see that the chaplains focus more clearly on the worldview dimension of their work. And on individual level, the chaplains learned about their signature, their preferred methods, their goals, clarifying their professional selves. For some, a process of normative professionalization even arises, in which they reflect on their normative dimension in their practices and the values beneath the surface that are important for them. Obviously, that level of professional values cannot be understood apart from their personal values and experiences. All these processes of clarification finally help chaplains to position themselves in the institutions among their colleagues. Concluding, we could say that processes of awareness play a crucial role in understanding how participation in research projects affects chaplains' professionalism. And four processes can be distinguished. The first three, explication of knowledge, becoming a more reflective practitioner, and increasement of efficacy, can be seen as part of their professionalism, while a regard to clarification and reinforcement as part of their professional identity. It is interesting to see that Clegg mentioned that in response to the psychologization of the profession, many ministers turned inwards, mystifying their role and emphasizing the process of the spirit, or I would say intuition, which are not amenable to ordinary explanation. And we observe this mystification in the Netherlands as well, as chaplains speak primarily in terms of attitudes, intuition, or a general presence about their profession. And I see two possible reasons for this mystification. First, for many chaplains, the professional domain and thus identity has become quite unclear as a result of secularization and process of pluriformity in Dutch society. And this could make it difficult for chaplains to describe the professional identity. And second, they are not used to speaking of their work in terms of theories or knowledge. In fact, this could indicate that much of their work is not only based on their professional intuition, but is also a kind of tacit or implicit knowledge. And the explication of their knowledge and the way of working makes them aware of their expertise and thus reinforce their professional identity, which is about meaning making and worldviews. Participation in research then helps chaplains to unfold their intuition and to develop a certain presence of mind or a Geistesgegenwart. Thank you for today. Looking forward to your responses. This was my presentation for today.
Thank you very much. It was really interesting to follow, and a lot of questions arising in my mind or comments, and I'm sure that the other participants feel the same. So I would say let's take about 5 to 8 minutes to get into a discussion. Thank you very much for the presentation. Who wants to start first? Just go ahead. I would maybe then start with a question. It's just understanding a term. You said with the point of efficacy that it's an enhancement of discretion. What does discrete or discretion mean?
Discretion is a term that is used very often in the especially in the literature of professionalism and professionality, and it's a term that indicates two things. It means the ability to make a good decision, so to balance and consider your decisions, but also to have some sense of autonomy to make a decision. So, for example, if you're only using a protocol and you're not a professional that is able and allowed to make a different decision for the sake of their clients, that's not professional, what literature would say. They would say then you're just applying the protocols. Every real professions have to have some sense of autonomy and also the knowledge and reflectivity to make a discrete judgment.
Because in the German term, Diskretion, it does mean in a way being confidential.
Yeah, in Dutch as well. Yeah.
Yeah. So and that of course for chaplaincy is a really interesting double meaning or third meaning in this ways. So thank you very much for clarifying this. I found it really interesting that being included in research work and considering yourself on different levels as a researcher and taking part in research is actually working against the trend of mystification of the chaplain's role. I think that's really an amazing finding. That's really striking.
Yeah.
Who else wants to comment?
Hey, I don't know if you can say anything about it, but I was curious, do you think it is typical Dutch chaplains to like don't be involved in, well, at the first not being involved in research and not reading literature, or do you think it's more across Europe, or what are your thoughts about that?
Well, I think it is a trend in all countries, but perhaps in different stadia, different times. So, like for example, in the United States, there was this formulation of the ideal of 3 levels of research literacy, which was formulated about 2009. But I think they stated as a goal because it's not yet practiced. So they want to achieve it because it's not yet the case that many chaplains are research literate. And I think there are many articles from especially the United States, of which I know that the emphasis was mostly on clinical pastoral education and not so much on research. And that's kind of shifting in the United States. But when it comes to Europe, I'm not sure actually, but perhaps our colleagues could say something about it at the moment. I'm curiously as well.
I just learned from a conference meeting via Zoom with the EuARe, European Research Institute for Chaplaincy and Healthcare. They had a study with the COVID-19 situation worldwide, and they had more than, I think, 1,600, I guess Axel knows more about that, more than 1,600 participants all over the world. And one of the findings was that in the, I think, United or Northern America, the percentage of chaplains with a doctoral degree is significantly higher than in Europe. So that would also support what you say, that the situation for chaplaincy is changing, less CPE oriented to more research oriented.
Yeah. Right, thank you, yeah.
So I can agree upon that. I think in Northwestern Europe, your question was, is it only in the Netherlands that chaplains less a little bit interested in research? I think in the Netherlands, Belgium, Germany, the United Kingdom, in the Northwestern Europe, we are very much interested in research and do much research when you compare it with the south of Europe. I am aware that I'm speaking in very general terms. What I found very interesting in your research is the mystification of the identity of the chaplain. I see it as a huge problem that we cannot really explain what we do in relation to other care providers. And that's a negative element in our collaboration. So I hope that your research can contribute to more clarity about our role and position in healthcare. I wish you very good luck with your research.
Thank you very much. Yeah, I hope so, to contribute to that as well. Yeah.
Yeah, that sounded like a concluding remark. It's really wonderful to learn about your project, and I think it's really a big contribution, just as Axel Lijois said. And I would turn over to Nika Höfler, whom all of you know already from the emails that we received by her. Nika Höfler is a PhD student at the University of Münster. She's originally from the south of Germany, and she has done her research work on case studies and the questions of efficacy of healthcare chaplaincy. And I'll just hand over to Nika to give her presentation.
So, thank you. I will give you a short presentation of our project in which we want to describe the effects of healthcare chaplaincy in a qualitative study. And with a few of the time, I have to hurry up a little bit. So I have structured my presentation as follows. I will give you some information about the project as a whole at first, where we want to describe the effectiveness of healthcare chaplaincy. I will give you some information on our first stage, where we work with case studies, and our second stage, where we work with narrative interviews. And these two stages are already finished. Then I will give you some preliminary results, but in a very short way, with our theory of vulnerability. And then a short information about our third stage, which is still in the planning stage and will start this summer. So, our research project as a whole. In our project, we want to describe the effectiveness of healthcare chaplaincy. We are a joint project, but this is not so important to regional churches and the University of Münster. And in our research project, we want to describe the effectiveness of healthcare chaplaincy. As you can see in the graphic, the effectiveness for all people involved in a healthcare chaplaincy accompaniment. The chaplain themselves, patients, relatives, and hospital staff, of course, and the institution as a whole, as a structural building. And we do it in 3 major stages. In the first stage, it's already finished. We work with case studies where we want to evaluate the chaplain's perspective. in a second stage, which is already finished also, we want to describe via narrative interviews the view of the other part, the counterpart of our healthcare accompaniment, the patients, the relatives, the hospital staff, the classical clients of healthcare chaplaincy. And in a third stage, we will do a statistical recording with time quotas and contact numbers, but this is still in the planning stage. And there we will work with quantitative methods in the first stages, which I did. First two stages I did the research. We worked with qualitative methods. And as you can see on the timeline, we started in December 2017. And this summer, we will start our last stage, and provisional end will be 2021. So the first stage, we work with case studies, the theoretical background. We asked, how do healthcare chaplains perceive and describe their contribution to a culture of spiritual care within healthcare? Where does something change in patients, relatives, hospital staff, or the chaplains themselves? So our goals were to collect and evaluate chaplains' narratives describing effects of their work and presence from their personal experience. And therefore, we worked with the method of case studies, just as a survey method. The case studies were written by chaplains from the accompaniment of patients, relatives, or hospital staff, singular encounters, as well as longer accompaniments. And the reports should contain the aspects, the context of the meeting, the background story of the patient and the institution, and then a reflection. And therefore we oriented on the healthcare chaplaincy case studies from George Fitchett and Steve Nolan from 2015, I think. The most of them know it. So there are some numbers, but with a few of the time I have to go on. And it's important to note that our evaluation method was the grounded theory. So the case studies just were the survey method. We collect the data via case studies, but our evaluation method were a method of qualitative research, and therefore the grounded theory. This is a method which is grounded inductively, directly in the words of the participants. And it is used to create a new theory. So this method is used when no theory exists yet. So our goal was to build a new theory on how healthcare chaplaincy works and how effective it is. And then we went on to stage 2, the narrative interviews. There we wanted to have the point of view of the clients of healthcare chaplaincy. So we asked patients, relatives, and hospital staff to describe the effects and changes of healthcare chaplaincy intervention. What does it depend on, and how do they determine this? And of course, is it consistent with the results of stage 1, the chaplain's view? So our goals were a direct questioning of the clients of healthcare chaplaincy, and we want to represent the reality in German hospitals. But now our problem was that we built the contacts via the chaplains from the 2 regional churches, and we just had exclusively long-term contacts, just people with whom a long and intensive relationship has been established through years of accompaniment between chaplain and the client. So this does not cover the reality of German hospitals, of course, because shorter and mostly one-off contacts, I think you all know it, with chaplaincy occur more often in the everyday work. So we switched to we split the process in 2 different work phases. At first, like I said, there was a call to the Association of Healthcare Chaplaincy, and therefore I talked to patients, employees, and relatives from long-term contacts. And in a second phase, we had interviews with short-term contacts in a hospital in 2 different stations. Therefore, a direct contact from the researcher with the local chaplain as a gatekeeper was important. And of course, the interviews were much shorter. And for the interviews, for both for long and short-term contacts, we had a guideline, of course, and the interviews were transcripted. So the method, the survey method for stage 2 was narrative interviews, as I said, and I have to switch the numbers, and our evaluation method was again grounded theory, like I said, and explaining in stage 1. And so a short look to our preliminary results. As I said, in grounded theory, the goal is to create a new theory, a category which describe the whole material and which is a kind of red thread through the whole material. And for us, this is vulnerability as a phenomenon in healthcare chaplaincy. And therefore, I will give you a short working definition we made. So in our theory, vulnerability as a genuinely human condition includes both the possibility of being hurt and the possibility of vulnerability as a weakness in systems or in relation to humans. Also a sensitivity and a susceptibility to mistakes and damage, as well as the ability to recognize them. So vulnerability is both. It is opportunity and it is a risk. It carries, on the one hand, the danger of being hurt or injuring others, and on the other hand, it is the enabling of life. It develops transformation potential, which is needed to be pastorally and chaplaincy effective and to adequately accompany people in vulnerable situations. So vulnerability is a human value for us in our definition that must be protected and handled with care in order to avoid actual injury and to be open also to the vulnerability experience of others. So for us, vulnerability occurs in healthcare, chaplaincy, or pastoral contexts on all 3 levels, which is the chaplain or pastor themselves, the counterpart, the clients, patients, relatives, hospital staff, and the institution as a whole. And on these 3 levels, it manifests itself in 4 dimensions: physical, psychological, social, and a spiritual dimension as well. And this due to the genuinely vulnerable situation in hospitals in confrontation and dealing with illness and death, of course, for all people involved. So our theory, our preliminary result is that vulnerability is the red thread of accompaniment in healthcare chaplaincy situations. It occurs on 3 levels: the counterpart, of course, the chaplains themselves, and the institution as a structural entity or building, and they're in 4 dimensions: physical, psychological, social, and spiritual. And therefore, of course, a reference to the current discourse of the phenomenon of vulnerability, Paul Ricoeur, Andrea Bila. But yeah, I think you all know them. So I have to go a little bit to hurry up through our theory. So to finish my presentation, 3 relevant observations on the description of effectiveness. First, effectiveness of healthcare chaplaincy is always described individually. It is individually describable on the own body or the own experience of the interview partners and, of course, of chaplains. The higher the individual, second, the higher the individual vulnerability is experienced by the person, him or herself, the more open the person concerned is to chaplaincy. And third, vulnerability is a very subjective experience for all involved, for the chaplain, for the counterpart, and for the structural building of the institution. So the first two stages are finished, and we start in this summer, the beginning of the summer now, the stage 3. This is a mistake. It have to be stage 3, not 2. Our statistical recording, but this is still in the planning stage, so I switch it in my presentation with a few of the time so that we have enough time for questions now. So yeah, statistical recording of time codes and contact numbers, but this will be done by another person, not by me. So I think I will finish now my presentation. So at the end, we want to have modes of action which should be developed. We want to show that healthcare chaplaincy is, with our developed parameters, that healthcare chaplaincy is an important benefit for healthcare systems in Germany and Europe. We want to show that healthcare chaplaincy cannot be described with medical markers and medical categories. So we develop parameters inductively in our material, in the texts themselves, in the interviews, and in the case studies. So thank you for listening to me.
Thank you very much, Nika, for summing up 3 years' work within a few minutes, like all of
it was very short, sorry.
Thank you very much. I'll just not say much and open up for discussion for about 5 minutes. So who wants to go first?
I have a question concerning understanding.
Yes, of course.
Did I get it right that the interviews of the counterparts are at the 2 stations, like generic and palliative stations?
Yes, yes.
I'm wondering how you did choose these 2 stations, or why?
It was a very pragmatical decision, because we still had evaluate the long-term contacts, and then we noticed that it does not cover reality in German hospitals. So we had to split our evaluation process. And so research helping person, not myself, another person, developed a contact to a chaplain in a hospital in Germany, where it was possible to be there for, I think, two days, and sitting there and waiting if someone wants to talk to them. So it was very pragmatical. We just talked to people spontaneously.
We actually searched.
So and there it was just the geriatric and the palliative station where it was possible to do this in this setting, because data security and all these things are very important for us. So we couldn't cover more stations and more hospitals, and we also had not so much time for this evaluation, because we just have 3 years for the whole process. So yeah.
But very exciting insights. I thank you for the presentation. Thank you.
Thank you.
Yes, I also have a question for you, Nika. Thank you for your presentation. Very interesting to see also that your research is focusing on 3 levels, like the chaplain and the client and the institution, and all 3 from their own perspective. I think that's very interesting. I was wondering with regard to the theme of vulnerability, which is of course related to the effects of chaplaincy, But I did not understand very well the relation between effect and vulnerability. I thought vulnerability is not an effect of chaplaincy, but something happens to this vulnerability. And what is exactly the effect that you see in your study then, or the relation between both? Yeah.
Yeah, we on the one hand, we are working out the effects of chaplaincy, which I also had done, but there was not so much time to. This were the graphics I had to switch. But vulnerability is our main category. So this is the origin of every healthcare chaplaincy accompaniment. So the vulnerability on all dimensions and all levels is important to be to make healthcare chaplaincy possible on every level and on every dimension. So the vulnerability is the origin of the efficacy, I would say, and it is the main category which go like a red thread to the material. The vulnerability from all sides, of course, not just at the patient's side or client side, but also on the chaplain and the institution as a structural building.
If I may try to add, I think with developing effectiveness that is not described in biomedical categories. At stage 2, we are finding out what is the context that vulnerability that effectiveness can be described. So the context is vulnerability or situations of vulnerability or a sense of vulnerability. And to describe the effects, we actually need the quantitative stage 3 approach to describe changes in the experience or in vulnerability. So does healthcare chaplaincy improve on situations of being hurt or injured, or does it improve in a way of helping omit situations of deep pain or injury occurring? So I think stage 3 will be essential. So right now we found out that vulnerability is the context in which effectiveness has to be described.
Yeah.
Great, thank you for this clarification. So it's like a kind of parameter.
Yeah.
Yeah.
That's the right word, yeah. I think we'll have to keep that in mind. Anyone else?
Yes, thank you very much for your presentation. I think it's very interesting, but I want to have some clarification. If I have well understood you, it's a description of the effects based on the experiences of the people involved.
Yes.
That's something different from effectiveness and proving the effectiveness and measuring the effectiveness.
Mm-hmm.
You see in the world of psychotherapy how they try to prove the effectiveness of psychotherapy. You don't do that for pastoral counseling. I think it's a safer option, because I think it must be very, very difficult to measure the effectiveness because there are so many influences on the well-being of the person that it must be very difficult. So I think it's better to describe it.
Yeah, we want to develop parameters for describing. We don't want to prove the effectiveness. We want to develop parameters for describing effectiveness. Sorry, maybe this wasn't clear. Yeah.
But it was rather clear, but I just wanted to be completely sure that it is not in your intention to prove the effectiveness.
With our parameters we develop, we want to show that healthcare chaplaincy is important, that it is a benefit. We want to show this, but we don't want to prove the
Okay.
effectiveness. We just want to show the effectiveness
Okay.
for a healthcare system as well. Yeah.
Okay. Thank you.
So thank you very much. I think there's a clear connection to the theme of professional and personal identity that we found in Niels Tentom's approach. So there will be some interesting questions that will maybe show up through all our presentations. I would again thank you, Nika, for doing your presentation and for the discussion, and then I'll turn over, before we get to a coffee break, turn over to Renske Kruisinga. Is it the right pronunciation?
Renske Kruisinga, thank you.
Kruisinga, okay. This is what happens when you have different people from different European countries together. It's wonderful to have you here. You are teaching at the Tilburg School of Catholic Theology. You studied journalism at the Christian University in Ede and Religious Studies University of Amsterdam. Your PhD thesis was on spirituality in cancer patients with the title Out of the Blue, Experience of Contingency in Advanced Cancer Patients. And your latest book that you published together with wonderfully Niels Tentom, I'll just show it right now, is this one that has just been published in April, Learning from Case Studies in Chaplaincy Towards Practice-Based Evidence and Professionalism. So I'll hand over to you, Out of the Shadow, Patient Spirituality Integrated in Shared Decision-Making, which is a perfect approach to hand over to the next presentation of Sebastian Farr. So Renske, the floor is yours.
Thank you very much. I am not sure how I can share my screen.
You are sharing your screen, and you
already?
just have a dia for sharing. Then you're sharing. Yeah.
Is this good? Yeah.
Okay.
Yes.
Sorry. Thank you for the introduction. I just switched jobs, so I'm now at the University of Humanistic Studies, just by the beginning of this month, so very new. And thank you for organizing this panel, Nika. We met you indeed at the conference we organized, Niels and I, together on the case study project. And I think it's very crucial for us doing research to know what others are doing, not only on a national level, but also internationally, because the field is not so big. So it's very good to know from each other what we are doing. It's already switched. My project is called Out of the Shadow, Patient Spirituality Integrated in Shared Decision-Making. And I want to talk you through this, explaining what it means by using these concepts. This is a project which is currently on a review at a Dutch organization, and it's the context of a personal grant. And I will be hearing if I'm through to the final round next week. So all your comments or questions are really welcome. When we face the end of our lives, the search for meaning and spirituality becomes more pressing, more important. Questions regarding what do I value in life are more relevant. And over the years, spirituality as a concept is gradually being included in healthcare, such as the World Health Organization put it in the definition of palliative care in 2002 by stating that palliative care is an approach that improves quality of life of patients by treatment of pain and other problems, physical, psychosocial, and spiritual. So it's really interesting that they also include the spiritual aspect in their definition of palliative care. But also the new definition of positive health by Mechtel Huber, and there it's called meaningfulness, in Dutch zingeving, is one of the 6 dimensions, but it's also described in terms of spirituality, like having a meaningful life, accepting life, being grateful, and so on. despite these, so at the one hand, spirituality is included in healthcare, you see, but despite these developments, including spirituality in all aspects of patient care is still problematic. And why is this a problem? Because there's ambiguity about the terminology. So what is spirituality? What do we mean by it? And especially in a Dutch context, where spirituality is often regarded as a vague concept. And it also may have a different connotation. Here you see the difference between a traditional understanding and a modern understanding, because in the early days in the Netherlands, spirituality was only for people who were really religious and have a spiritual experience. But in a modern understanding, spirituality is much broader. Also, secular people can have spiritual experiences. But there's not only ambiguity about the terminology, but also unfamiliarity regarding how really put these concepts into practice. We know that it's important to address these issues, but who should address these issues and how should we address these issues? There are still questions we do have. And one practice in which spirituality is hardly ever addressed is shared decision making. And that struck to me because decisions regarding treatment, decisions regarding advanced care planning are preeminently linked to spirituality. Think, for instance, of ventilation or palliative sedation. They're all linked to spirituality. But what then is shared decision making? Shared decision making is a physician and a patient discuss the benefit and harms of the available options, and also patient values and preferences to come to an agreed upon decision. So far, so good. But studies show, however, that patients' values are often not or inadequately discussed within SDM. So also physicians and patients have shown to prefer focusing on the short-term treatment, controlling the illness, and rather than anticipating on what is to come. And up to now, mainly professionals with medical and psychological perspectives are involved within SDM. So my proposal will be to include spiritual counselors in this process. Especially to tackle the problem with clarification of patients' values, because I think they are trained, especially to clarify patients' values. The aim of my research is twofold: to concretize the terminology on patient spirituality, and also to offer practical guidelines for integrating spirituality into healthcare. Because I said in the beginning, this is a problem. My central research question will be, how can spirituality be best addressed within shared decision making? And I want to include 3 key objects to understand the role of patient spirituality and also their underlying values within SDM. And second, to train spiritual counselors in values clarification and communication also, and to examine the effect of the training. And the third one is to improve interdisciplinary collaboration, because when spiritual counselors are part of the process of shared decision making, that a physician has to refer the patient to a spiritual counselor, there will be more interdisciplinary collaboration, I think. So starting with the patient's perspectives, I will conduct in-depth interviews about their spirituality, their underlying values, and I also want to explore the experience of physicians and nurse practitioners with SDM, and also to ask them about their vision on how to include spiritual counselors in this process, because they know the process really well, and they also might know where the help of spiritual counselor would come in handy. Then I want to do an open call for spiritual counselors to describe case studies on shared decision making, and on basis of all those, and do in-depth interviews also with spiritual counselors, and on the basis of all these informations I will design the training course for spiritual counselors, and it will be on values clarification and communication. I want to divide my research into 5 phases. So in the first phase, the preparation, arranging forums, seeking contact with the hospitals, but also do a literature research on all the data on patients' values, spirituality, SDM. In the second phase, I want to do the in-depth interviews, but also organize the open call to spiritual counselors, and that are all spiritual counselors who work in a hospital setting. And also the patients are all palliative patients, so patients who receive palliative care. In the third phase, I want to develop the training course. And in the fourth phase, I want to provide the training for spiritual counselors and also examine the effect of consultations between patients and trained spiritual counselors. So see if the training really works. And well, here you see a timeline pre-corona, so it is all extended a bit, but it is for a 3-year project. And yeah, I really hope I receive the grant so I can be able to work it out further and to really get on planning. So if you have any questions, remarks, suggestions, it would be really nice.
Thank you.
Thank you very much for this introduction, and of course keep our fingers crossed to so that you can receive the grants, because we all will be having profit from your research and the project, also the implementation process. So the discussion room is open for, again, about 5 minutes. Who wants to go first? So I'll just start again. Oh, I saw there was a finger by Nika.
Yes. Can you, sorry, Rancic, can you switch back in your presentation? I wanted to ask, how do you evaluate your material? That wasn't clear to me. Do you?
Which slide do you
use a special method to evaluate your material?
The training course.
The training course.
Yeah, I'm not yet sure about that. I haven't thought that out, but I think the training course should be evaluated on like its effectiveness. Does it what it says it does? But also some goals will be derived from the interviews. So what patients think it's really important in shared decision making that we want to put out in the training, and then we will evaluate, like, is the goal of the patient, is it at the end something that the training does with spiritual counselors. This not only from the spiritual counselor's perspective, but also from the patient's perspective. We want to include that.
Okay, thank you. Thank you.
I would maybe add on that you're doing interviews with nurse practitioners and physicians and spiritual counselors as well, as I understood.
Yes, and patients.
And patients, okay. Yeah. And the situation where you're focusing is shared decision making. And I just turned back to Neil's presentation on chaplains' professionalism. I found there was a switch in the terminology. While in Neil's presentations, we had the healthcare chaplaincy, and in your context, it's now the spiritual counselors. Is there a program, a rationale behind the switch of terminology? How would you describe that?
No, it's always a question how you label things. Which label do you use by describing these persons? Chaplains do have the term chaplains, and chaplaincy does a bit have the connotation of a religious background, and spiritual counseling is more generic. Yeah, it depends on for which journal you are writing and to which people you refer, which terminology you use. It doesn't really matter, but in my research, I'm really interested in the hospital setting, the palliative patients, and all spiritual counselors who work there, also humanistic chaplains, spiritual counselors. I will not be focusing on the religious backgrounds so much. It will be more from the patient's perspectives, like what are they defining as being what is helpful for them for making the choice, and really the values they have. So I understand spirituality as a really broad concept, and really all questions on what is value in life. These are important to make the medical decision as well.
If I would follow up on that, it might be really interesting to understand whether it makes a difference, especially in the situation of shared decision making in ethically critical situations, if you follow a more religious concept of spirituality or a more humanistic or generic understanding of spirituality, if there is any difference, because I would suspect that there is a hidden hypothesis if you have an open understanding of spiritual counseling or an understanding of a more closed religious chaplaincy-oriented support within shared decision-making, that it does influence the process of decision-making. So I think that would be
I will expect as well that there is a difference. But in my research, in my PhD, I focused on, I also had a broad definition of spirituality in cancer patients. And there I found that only, like, I don't know, only 5% of my data was on really religious people with and most of it are people who say, I'm not religious, I don't have anything with it, and then they started talking, and I found out there was a lot of life view, a lot of spirituality, what they were saying. But if you have this very narrow definition of spirituality, or you won't be able to really grasp what is now in the Netherlands, the main patient group.
Okay. Any more comments? Yeah. I see that Axel Lijois is nodding, and Nika signals to me that we have to watch our time frame. That's okay. This is still Axel Lijois.
Okay, just a small remark connecting to your last comment, and it is about the definitions of spirituality, religion, and the secular on one of your first slides. I think you have elaborated more on that, but in your project, can you give the other one with the scheme?
With the?
With
the next
scheme,
one? Yes.
the tekening. Yes. Secular, in relation to spirituality, I think it should be secular worldview. But I think it's much more complex than that. Spirituality has different meanings, also in English and in Dutch. There are different connotations. And I think the dichotomy between religion and secular worldview, there are more gradations in between. But I know this is a scheme in a very short presentation. But generally spoken, the distinction between these concepts is very difficult. And I think you have to elaborate very well on that, so that people cannot give remarks when you submit your project. But I think time is too short to start a discussion about these concepts.
Yes, I know, and I know it's more difficult than this this scheme, and I will let your remark. I will understand it, and I will elaborate more on that. Thank you.
I think that's exactly why we're doing that at the European Academy of Religion, because it's one of the most pressing questions, I think, within European countries and the different cultures that we come from. The Dutch situation is totally different from, I'd rather say, the Spanish situation. So it's really interesting to follow up on that and to learn more, because we're not only oriented on the North American situation. So we'll have to understand what it means, especially using terminology. My suggestion would be, if that's okay for you, that we have a short break. And I would say until 9:50, would that be okay? Because we started 5 minutes late because of the switch of the Zoom conference. So about a 10-minute break, so you can get some coffee or a drink, or maybe go somewhere else and smoke a cigarette or whatever. And we'll return to our conference room at 9:50. Okay. And then I'm looking forward to Axel Lischwartz's presentation.
Okay.
Thank you.
Thank you.
See you in a moment. I'll stop the